what
You never lived in the city?
No. Yeah. Yeah. So, yeah, well, he had, he's a PhD. So, he had some background, but and anyway, you're right. Public, hey, being a superintendent schools, public relations, that's what I did. Work in public relations. Perfect.
So let me get on your calendar right now. You're the one that has the busy schedule.
Just talking about two terrible talk about it tough.
Oh, yeah.
It's a tough week. Everybody says, how you doing? I'm doing great. That's it. No, it was tough.
Oh, yes.
We came over on the boat.
And now I'm very biased.
Exactly. I've got a whole basketball.
You can just join us. We're usually right on the dock right next to the stadium. And if you got nothing to do, you might have to walk up. There with cards. We're right in front of the Kevin wants it. It takes about an hour and 58 minutes to get there.
I got your email.
Frank, you've been going all the game. I don't mind. You should come down and see my office.
It's always over.
We're usually right on the dock. We're not the big boats. You have to be over 40 feet with the big boats. We're 39. So we're the first. What's that? Oh, he wasn't.
Good thing you were there. Why don't you take my wallet?
No, it's not. I have never been back to Washington. It's so rough.
And not
So
I go to
coming into the wind, it's like being out there. Yeah. Right traffic was going down. We had a hell of a time just getting off the dock. By the way, to get one. It's like 30 mile an hour wind. The boat is like but by the time the evening I went home, it was black. So we just committed. Yeah. Got nothing to do. We usually get there about 2.5 hours.
Let's go ahead and get seated, and we'll get started in just a second. So the word of the day is additives. And I won't say anything political. I'll get in trouble. So Ron Simon, a good friend, someone who's been up here a number of times before. When we last spoke, he said he was getting tired of the sunshine in San Diego, and he needed a dose of gloom and doom, and he had to come up to the Northwest. So he's got a lot of material, and so I'm not going to BS here for long. And I know... All right, now you get it. Go on and tell Joe. Are you sure that's one? So I know he can stay beyond 8, so I encourage anybody, especially fellows, with a Q&A, pragmatic questions. Ron, I've heard him say at one point, he would challenge anybody to anything. I've heard a lot of silly things in life, but you heard that one year. So I encourage you to stay, and we can have some open discussion and definitely ask some questions along the way. So Ron, thanks for coming.
Yeah, thanks, Lynn. It's always a pleasure to be up here. I really enjoy it. So a couple of things. What Len meant was we see a lot of people, at least in Southern California, I'm not so sure it's the case up here, who think that they react to almost anything or literally everything. And I've developed 4 criteria by which you could actually challenge anybody to anything, as long as they can give you these 4 criteria. So it could be, their symptoms could be totally subjective. I mean, it really doesn't matter. So if you want to discuss, we can talk about that. It's kind of related to additives because they're all chemicals. Most of these people think that they're allergic or sensitive to chemicals, and we have had some interesting ones. Then a background about why I picked this topic. So we were trying to work out the usual program where one of the pharmaceutical companies will pay to have the speaker come up And that was right at the time. We had it all arranged, and then Merck pulled the plug on their slit, and then that was the end of that trip. But actually, I have an unrestricted research grant from the Coca-Cola company, of all things. So I decided that to sort of use that money, I would do something maybe germane to what their interest would be, which is reactions to food additives. But Len wanted me to talk about aspirin and NSAIDs, so it all came together in what is a lot of slides, but I don't think it'll be that long to talk, but we'll find out. All right, so what I'm going to see is in the handout. Oh yeah, and if I don't cover everything, everything's in the handout, and everything and anything you would want to know about adverse reactions to food additives isn't up to date. I write that chapter. So really no disclosures, except that I did fund my way up here, if you will, with this unrestricted research grant. Last time I gave a talk on food additives, they said to me, I'm sure you don't really want to be here, so why don't you put a picture, a slide in your deck about where you would like to be. So this is our second home, just an hour south of San Diego in Mexico. That's my dog Carmela coming around the bend. And it's hard to see maybe from the picture, but we are literally above the ocean. I look down at the ocean. So that's why when you're upstairs, it looks like you're on a cruise ship, because you get that cruise ship look. It's a fun place to go if you want to come down and join me one of these days. All right, so there are tens of thousands of food additives that go into our diet, and a lot of them do a lot of different things that are good. Some of them just are there for coloring and flavoring, but there's a lot of different ones. Again, really tens of thousands. Most of them are on what's called the FDA GRAS list, GRAS, for generally recognized as safe. Meaning that they've never really been tested, but they've just been around for so long and nobody's really complained about them, so they're on that list. But over the years, there's sort of the list of suspects. And this is really the list of the food additives that people wonder about and have reported and talk about as being causing adverse reactions. And we'll really go over pretty much the whole list. Just so that you know, there's a lot of additives in the medicines we take as well. And a number of years ago, when this was a trade secret, I was able to get the total contents of what was the most popular female hormone replacement at the time, Premarin tablets. And there's 25 different ingredients on this slide, including at the bottom the estrogens. But almost every single one of the list of suspects I showed on the prior slide is in this one tablet. But also interesting things like carnauba wax and shellac and other things like that. But my point of showing the slide is really, we do see patients who talk about having what sound like bona fide reactions to a number of different drugs that are totally unrelated. So before you just totally pass that off as the patient is sort of misattributing things, it's conceivable that it's one of the additives in the drug and that's why they're reacting to so many different classes. So this drug does have the three things that really started the whole thing off, which was FD&C yellow number 5, which is Tartrazine, and then Parabens and Benzoates. So this drug, this food additive, Tartrazine, really started with opening the Pandora's box and really opened everything about what people thought were adverse reactions to food additives. This is essentially an inert chemical that really can't react with anything, but it started the whole entire story. And it really dates back to an article written by Steve Lockey. People in the audience know who Steve Lockey is, back in 1959. And I don't really get the story, right? So they reported 3 patients who supposedly had a reaction to Tartrazine. You know, we always talk about the index case, but if you have one case, you don't usually report that. You wait till you have a quote-unquote series. They waited until they had 3. But the index case was a patient who they described as being in the midst of a reaction anyway that really had nothing to do with the Tartrazine. It's really completely unclear to me from reading the paper why they thought the person was reacting to Tartrazine. And they didn't do a Tartrazine challenge, but this was their index case. And then they found 2 others. The second patient was challenged, but it was an open challenge, and they gave him this bright yellow substance sublingually. So they're walking up to them with this bright yellow thing, putting it under their tongue. And then they describe the fact that the patient reacted, but they don't describe what the reaction was. They could have been shocked at putting this yellow thing under their tongue. The third patient was also challenged, open and sublingual, and guess what? They felt funny inside their mouth where they put this Tartrazine. And this is the index thing that started out fact that tartrazine causes adverse reactions. So over the years, there's literally no case of anaphylaxis or anything like that to tartrazine. It's always in other disorders. So the two big disorders for adverse reactions to food additives are urticaria patients, chronic idiopathic urticaria patients, and asthma patients. So we'll start with a little bit of the data on why people thought that people reacted to additives. Oh, can you go back? Okay. So over the years, starting in the 70s, there were these what I call wholesale challenges. They would bring in patients with chronic idiopathic urticaria. In the better studies, where they would even have a placebo control, the placebo was always given first thing in the morning, and then you would give the food additives after that. Well, all these studies were based on asthma studies. In asthma studies, you withhold bronchodilators before you do challenges, right? Because otherwise you wouldn't see any asthma. So they withheld antihistamines. So imagine taking somebody with chronic idiopathic urticaria, withholding their antihistamines the day before, giving a placebo first thing in the morning when they're closest to their last antihistamine dose, and then over the course of the day just giving other food additives. Of course they reacted to the food additives, but they were really just showing the fact that they had chronic idiopathic urticaria and were off of their antihistamines. So this was all through the 70s, all through the 80s, all through the 90s. These sort of studies were coming out. And no matter how many editorials we wrote and how many articles I tried to get rejected, they always found a place to be published. So with a fellow a couple of years ago, well, actually it was a lot of years, because I don't know if you know the name John Basso, one of the last author on here. He was a fellow quite a long time ago and has been doing a lot of Aspen challenges on the East Coast. He's really the first person to bring Aspen challenges into the community. Anyways, the study was going on for a long time, but finally we pulled it together a couple of years ago. And I'm not going to bore you with what we define chronic idiopathic urticaria as, but you can imagine that we were pretty careful about ruling out other conditions. But also, this was a group of patients that were, I would call, high risk, meaning that 43 out of 100 subjects were avoiding food additives because they thought that they were reacting to them. So they weren't just a general CIU population. They were, in my opinion, high risk. And they were avoiding all the different additives that you could imagine. And then there was a group that just felt that they were sort of chemically sensitive, so they were avoiding all chemicals. We used big doses because I wanted to be sure that nobody would say that we didn't give them enough. So for something like MSG, we gave 2,500 milligrams, which is a lot of MSG. But anyway, these are all really at the 100% or more daily intake of somebody who actually will eat a lot of these food substances. There was no doubt that we gave enough. Doing urticaria challenges is one of the reasons why the other papers I felt were done poorly is, well, a lot of the papers would describe reactions in patients who had urticaria as not even urticarial. I mean, some of the patients got headaches during the studies, or they had joint aches and pains, and they considered those positive challenges to the food additives. The better studies at least had hives as the endpoint. But how do you determine whether somebody who has chronic idiopathic urticaria is getting more hives when they have had the food additives? And even if it's pretty clear they got more hives, how do you know that that wasn't just spontaneous? On that particular day, they were going to get more hives. There's a lot of problems with doing these challenges. But what we did was we would taper the antihistamine dose. Let me just make sure I go to the next slide. Yeah. We would taper the antihistamine dose to what we call the minimum effective dose. So it was a dose that kept the patient relatively comfortable, but they were still hiving. And then we would give them the challenges, and then we would actually do what we consider to be semi-quantitative ways of determining whether or not they had a reaction. So there would be a single initial all-day-long placebo challenge to give us a baseline for their urticaria. And we actually divided the body up. Now if you do, I don't know if anybody did the Xolair trials, but the Xolair trials sort of adopted this with the total urticaria score, total skin score. So you take the body surface areas, like you're estimating what percent of the body was burned. And there are 9 surface areas, so there's like each one about 11% of the surface. And then you just count the urticaria there, or you can just get a feeling for it. And we decided that if there was 0 to maybe a quarter of that surface area covered with hives, they would get a 1. If it was a quarter to a half of the surface area, that would get a score of 2. If it went up to 3/4 of the area was covered with hives, it would be a 3. And if it was just a few urticaria, it would be a 4. You add up all the areas and get a skin score. So we were actually getting a semi-quantitative way of doing this. Because our bias was that people didn't react to food additives, it would have taken me more than a lifetime, you could imagine, to do each individual food additive with enough patients. So we basically just gave them a handful. We called it a mixed additive challenge. Because another criticism, I knew another criticism of the work was going to be, oh yeah, so that they're not going to react to just tartrazine. They have to have tartrazine plus another one to put them over the threshold. So we just gave them a handful of food additives. And then anybody who reacted to that, then we brought them back and did very careful in a clinical research center, double-blind placebo-controlled challenges. Well, only 2 people out of the 100 even had a positive skin score change with the mixed additive challenge, and neither of the 2 had any reactions to any of the additives when we split it up. So despite, again, decades of the literature suggesting that CIU patients are sensitive to food additives, statistically we could say with 99% confidence, not even just 95% confidence, that there's really just no association between food additives and urticaria patients, so there's no reason to have patients avoid them. So what about additives in asthma? Well, it's really, to me, amazing that, okay, so tartrazine is also the single case here as well. So we've now done hundreds. This study was published years ago, and we've yet to find a single asthmatic who is tartrazine sensitive, even in the AERD population, which was supposedly very high risk. And there were studies that suggested that 30%, 50% of AERD patients reacted to tartrazine, and there really were none. I think the reason why they got their reputation is most AERD patients have very bad asthma, and back in those days before inhaled corticosteroids, before LABAs, anything like that, it was very difficult to control them, so they were just reacting to everything, and they would react to things that were colored yellow and things that were not colored yellow, and people thought that they had reactions. So, I didn't put this slide in here because I wanted to save time, but it's interesting that the index case of tartrazine-induced asthma also occurred in 1959, the same year as the paper on the skin. And it was the same story where they had a patient who there was really no good reason to think they were reacting to tartrazine except that they had uncontrolled asthma. And in those days, it was actually a very popular asthma medicine that was colored yellow, so it got implicated. And they did a challenge without PFTs, and the patient said they felt a little short of breath, and that was a positive tartrazine challenge. It was amazing. But I don't think tartrazine asthma exists. So if tartrazine, urticaria, and asthma don't exist, there is almost no data on any of the other colors, these azo and non-azo dyes. So I really don't think that there's any reason to worry about any of them in terms of adverse reactions in urticaria patients or any other patients. Now, on the other hand, sulfites had clearly caused asthma, but for the most part now, they're out of the food chain. The only time we see anybody these days really reacting to tartrazine is somebody who will open up a package of dried fruit. So they're all gassed with sulfur. Well, they're not all gassed. If you look at dried fruit and you look at the ones that are plump and robust and colorful and juicy and sweet, they're gassed with sulfur dioxide. If you look at the ones that are all crenated and kind of chewy and not very colorful, those are the ones that are not. So most people choose the ones that look really nice and taste really good and soft. So they're gassed with sulfur dioxide. And if somebody has a bag of them with asthma and opens up that bag and gets a whiff of sulfur dioxide, it's well known that asthmatics have hypersensitivity to sulfur dioxide. You could do sulfur dioxide challenges in asthmatics instead of methacholine challenges if you wanted to. So naturally, they would have a little bit of asthma from that. But I don't call that a sulfite-sensitive asthmatic. That's just an asthmatic. So for the most part, although sulfites were producing serious, life-threatening asthmatic reactions, you just don't really hear about it much anymore. Monosodium glutamate is a very interesting thing. So this is MSG. The industry says that it's there for flavor enhancement, but it doesn't. There's a big debate in the world because a lot of Asians do think that it actually imparts a taste, an umami taste to food, but Westerners kind of have a difficult time tasting that. But what it definitely does do is stimulate nerve cells. It's an amino acid that's neuroexcitatory. So when MSG sits on your taste buds, it excites them, and it certainly makes you think the food tastes better. So in a sense, it's almost a food adulterant, if you will. But as people are trying to be more helpful in their eating habits and maybe choose less salt, less fat, it's kind of nice to have something that will stimulate your taste buds to make you think that the non-fatty, non-salty food actually tastes better than it does. So that's one of the reasons for it. And again, while other things were milligram quantities, we had to put gram quantities of MSG because in a highly spiced meal, there may be 2, 3, 4, 5 grams of MSG in the meal. It's pretty clear to neurologists that it can trigger migraine headaches. Again, it's not an allergic reaction, but it can trigger migraine headaches. Again, it is neuroexcitatory, so wouldn't be surprised. And back in the day, like when I was a kid, people talked about the Chinese restaurant syndrome, and there was an intense amount of MSG, at least in the Chinese restaurants in New York. And people would be sitting down to a Chinese meal and all of a sudden start sweating and having headaches, muscle aches. It was really weird. No one could ever reproduce that in a lab, in a double-blind placebo-controlled challenge, but yet everybody would talk about it. It was just very, very interesting. Okay, but as far as MSG goes, there was a group of people who thought that it could trigger asthma. So again, we had to sort of dispel that myth. So we took 65 patients. Again, we felt that they were high risk because, again, the 8 ERD patients were felt to have the highest risk for developing MSG asthma. So we had 50 of those, and the other 15 patients were all avoiding MSG because they were sure it triggered their asthma. We did double-blind placebo-controlled challenges, and nobody reacted. So I don't think MSG asthma is an issue, but there is a very interesting paper published, a letter, it was really a letter in Lancet a number of years ago, in which they described a single patient that had angioedema after eating MSG. But this was 16 hours after the ingestion. And I can't even imagine a mechanism for that. And it was only a letter, but it was a very convincing letter because the patient actually underwent multiple placebo-controlled challenges, and on 2 of them actually had angioedema from MSG, and on the placebo-controlled challenges did not. So it's something to at least be thinking about. I mean, this was in 87, and I don't know that no one's ever reported it again. I don't even know how you would know if it with that kind of a delay, but it's at least something to be thinking about. The aspartame story, the Nutrasweet story, is a really, I think, a really interesting one. I mean, this is, as you probably know, it's just a dipeptide. Why in the world should that be producing any problems? But very shortly after it was approved by the FDA to be in soft drinks, it was initially approved to be in baked goods, and there was no reports of any problems with that. But as soon as it was allowed to be in soft drinks, there were 2 subjects who were reported as having urticaria from aspartame, and they had very nicely reported, very elegantly done, double-blind placebo-controlled challenges, and they both reacted only to the aspartame. So that really set off, I don't know if you remember this, when it was reported at the Academy meeting before it was published as a paper, it just kind of rocked the world, if you will, because so many people were drinking diet sodas at that point, and there's a lot of chronic idiopathic urticaria. Well, there was never another reported case. And I don't know if it's on the next slide or not. Let's see. Oh, sorry. Yeah. There was a study that was done that, again, people chronic idiopathic urticaria, and it didn't react. And it was one of the food additives now, or mixed additive challenge. I don't really think it's a problem that it was there. The issue of aspartame and headache, I think, is a really fascinating one because it says a lot about, well, it's an important issue if it can trigger migraines, and it says a lot about society and how we assimilate and communicate messages. So in late 87, a study comes out in the New England Journal of Medicine looking at aspartame and headache. So what does that tell you? New England Journal of Medicine means what? This is what the world heard, right? This is reported on the news because it's a big deal. Can aspartame cause headaches? Okay, so they had 40 subjects. They were migraineurs, and they thought that if they drank these diet sodas, it would trigger their headaches. So clearly they were a high-risk group. They did what we would normally do. They would bring them they were brought into a clinical research center. They gave them either aspartame or a placebo, and then they counted up who had headaches on placebo. Because they're migraineurs, they're going to get a headache spontaneously. Who had headaches when they got placebo, who had headaches when they got aspartame, and they couldn't tell any difference. So that's what they reported. Again, very well done study. That's what the world heard. That was late 87. In early 88, a study came out in the journal Headache. So what does that tell you? Who here reads Headache? Who here has ever heard of the journal Headache being reported in the national media? So nobody knows about this study. They did, in essence, a real-world study. They gave patients a month of aspartame tablets to take at home, and then another month placebo tablets to take at home, and then the patients would count out their headaches and the severity of their headaches. And it was very clear results, that during the month that and it was a crossover design, during the month that these patients took the aspartame, they had clearly more headaches and more severe headaches than they had when they didn't take it. But nobody knows this result. So to me, you have it, and also how do you put the two results together and make any sense out of it? So it suggests to me that a single dose of aspartame may not trigger a headache, but maybe it lowers the threshold for all the other things that trigger migraines to trigger migraines. So I only bring it up because sometimes intractable migraines can be a horrible thing to have, and if you have patients who have it, if they're willing to get aspartame out of their diet, everybody is, maybe it'll be of some benefit to them. Okay, so BHA and BHT, butylated hydroxyanisole, butylated hydroxytoluene, they have a lot of different uses. It amazes me that the same compounds can be used to keep breakfast cereals crisp, but also chewing gum soft. I'm not a chemist, but I think it's just amazing that the same molecule can do both. This has never been implicated in asthma. There was a study that suggested that it could trigger chronic idiopathic urticaria, but again, it was an older study. Our study, I think, much better done, showed that it didn't. But there's another really interesting BHA-BHT story that I think is worth knowing because it says things about our culture and society as well. So back in 1986, we reported a woman who had a truly toxic reaction to BHA or BHT. She was nauseated, vomiting. She felt out of her life. She was confused. The story was a woman was from San Diego, went on her honeymoon to Lake Tahoe, very popular honeymoon place. Guess what she got on her honeymoon? She got a lip sore, canker sore on her lips. Not a good thing to have when you're on your honeymoon. So she went into the local, quote-unquote, health food store where they had this encyclopedic volume sitting on the front counter, and she's going through it trying to find a remedy for cold sores, and it turned out that they told her to take, I think it was 4 grams of BHA, and that would be good for her cold sore. That's higher than the LD50 for rabbits. So for the peanut gallery, as what TVs are, the people in the back. So LD50 for rabbits that's the dose that would kill 50% of the rabbits that got it. So this dose was higher than that LD50. So she had basically a toxic reaction to it, but she got this product in a quote-unquote health food store. But it also is important because I see this all the time, and maybe it's different here. Patients will come in and I'll look at their medicines in the EMR, and I'll say, oh, you have allergic rhinitis, but you're not taking an antihistamine? Well, of course I am. I'm taking Allegra. Oh, it's not in here. Well, it was over the counter. I didn't say anything about it. Now that we have the intranasal steroids over the counter. But even if patients say they're over-the-counter drugs to the intake nurse, they don't talk about their supplements. And supplements may be doing things to people, so it's always worth to find out about that. Now, parabens and benzoates, we know that they can cause allergic contact dermatitis, right? Because PABA, P-A-B-A, the original sunscreen that could cause allergic contact dermatitis, but whether or not it could cause other reactions is unclear. It didn't come out very well, but there were some studies that suggested that they could cause asthma, but the ones that were better done showed that they don't. Include one by Dick Weber at National Jewish. So there's really no good data that suggests they cause asthma. Again, our data in urticaria suggests they don't cause urticaria, but they actually can cause anaphylaxis. What's so interesting about it is the reports of it have nothing to do with parabens, so you would never know it if you read the literature. I came across this because years ago we were interested in allergic reactions to local anesthetics, which we know now for the most part just don't exist. But in these 2 articles, both published in 1969, the title of the paper is Anaphylaxis to Local Anesthetics, and that's part of how people started to initially think that they could cause anaphylaxis. But if you actually read the paper, it was the paraben preservatives. And then the same thing happens. You read articles that are called the allergic or anaphylaxis to steroids, and it's not the steroid molecule. It could be other things other than paraben, but it's never the steroid molecule. But at least 2 or 3 of them have to do with the fact that they're preserved with parabens. So you should always be thinking about that if you see a parenteral anaphylaxis. What's so interesting about these patients is that there was nothing mentioned about the fact that the oral medications that they're taking are commonly preserved with parabens, and a lot of foods that we eat are also preserved with parabens. So it's clearly not that. It has to be parenterally administered, but something to be thinking about for anaphylaxis.
Do those drugs still generally contain parabens?
Yeah, they're still used because they're generally benign, but there are those reports. And so, local anesthetics do as well. Nitrites and benzoates have been implicated by, you can see every one of the papers has the same first author. So that author feels that they can cause chronic pruritus. And it may be different here because there's so much more moisture in the air, but chronic pruritus, our dermatologists now just want to do laser treatments. Nobody wants to see a rash anymore. So we're seeing rashes all day long now. And one of the most common dermatologic consults that we get isn't even for a rash, it's just for pruritus. So this author feels that chronic pruritus can be related to nitrates and benzoates. There are case reports. I mean, I think there's like 2 or 3 in one of the studies, 1 or 2 in the other studies. It's always improvement with avoidance, and then they bring them back, and either they challenge them or reintroduce them, and they feel that they get more pruritus. But it's the same sort of thing where if the pruritus recurs within 24 hours, it's considered a positive challenge. And these are, again, itchy people. They always give the placebo first, followed by the other additives, and they always withhold whatever medicines they're taking to try to keep them from itching. So I personally don't buy it, but this author has been very prolific in publishing about it, and it really can be a very vexing problem, so maybe that's worth thinking about. But what's amazing to me is I've shown you basically all this data about how the chemical additives and preservatives don't cause a problem. Why would that be surprising? They're basically inactive chemicals. What do allergic people react to? Natural things. So and the food industry and the drug industry is a very consumer-driven industry. So they get the sense that consumers don't want, and you see what's happening now, don't want chemicals in their diet. They're very happy to go out and try to find substitutes. They find all of these natural substitutes, but guess what? That's what allergic people react to. So I listed these because there are well-documented cases of anaphylaxis from every one of these quote-unquote natural food additives. So that's actually more of a problem, but it's what the consumer wants, so it's where the industry is going. Okay, so I wanted to finish this part of the talk with talking about hyperactivity, because that's now another subgroup that's gotten a lot of attention recently. Again, through the 70s, 80s, 90s, it was really mostly urticaria and asthma, but now it's really hyperactivity. So I thought it would be worth talking to you about it, because I can't imagine you don't see kids whose parents think that they're reacting to food additives or colors or whatever. So this really started in 1973 when a Dr. Feingold, who was a pediatric allergist in Kaiser at Northern California, was giving a presentation to an AMA convention. I don't know how he got invited, why he was invited, but just gave this presentation saying that in his opinion, hyperactive kids react to chemicals and particularly to food additives. So then he published a book a couple of years later about why is your child hyperactive, without any data at all, but recommended the KP, the Kaiser Permanente diet that he had developed, which is not only no artificial colors, but no preservatives at all, no salicylates, no sugar. Okay, so it is a myth that sugar causes hyperactivity. And it certainly is a myth that salicylates can. Dietary salicylates, again, are also totally inert. They don't even cause a problem in ERT patients. How are they going to cause a problem in hyperactivity? Well, we'll look at the data for the artificial food colors, the AFCs. But if you look at the oligo, and it's funny, so none of them are antigens, right? They're just a bunch of inert chemicals, but he called it the oligo-antigenic diet, which is great because they're not antigenic. Okay, so there's a bunch of literature out there that suggests that hyperactivity and artificial colors are related, but these studies have to be done like triple blind. Okay, so the child really needs not to know. It has to be blinded to the child. It has to be blinded to the person who's giving the additive or not. It needs to be triple blind because the observers need to be blinded. The parents, the teachers, the psychologists, whoever it is that's doing the assessing also has to be blinded. And that's where most of the studies fall off. So finally, in 2012, somebody published a meta-analysis of what I would consider, and then the author considered, the well-done, at least double-blinded elimination diets or challenge studies in hyperactivity. And there was a small, not statistically significant change in the parental reports of symptoms, but no changes at all in the teacher or psychologist reported symptom changes. So the author concluded that there's no relationship. But the zealots, the people who really believe that hyperactivity and artificial food colors exist, looked at the small change in the small numbers of children that the parents reported and said this is still a problem. So sometimes you just can't use data to convince zealots as to what is going on. But this is, to me, the best paper. And so just so that you know, the food allergy practice parameter says that there's no relationship. And if you look at this, it's actually a strong recommendation with A evidence, because there are double-blind placebo-controlled trials. And that was published in 2014, and I was part of that, and I was also part of the NIH food allergy panel, which said that in 2010, which was pretty bold, because that was even before the meta-analysis came out. So again, all the data that exists, the good data that exists, suggests that there's no relationship between hyperactivity and artificial food colors. Okay, so I'm going to switch gears and talk about reactions to aspirin and NSAIDs. Wasn't really sure what to cover, so I just put in sort of a potpourri of things. I understood that you're doing aspirin challenges, so I thought you might want to see some things that are germane to that. But again, I'm happy to stay around and answer any questions. So just to start out with saying that once somebody can ingest 325 milligrams of aspirin without a reaction, they are desensitized. So we definitely no longer go to 650. If you get to 325, you're done. We've never seen a patient react to 650 who tolerated 325. They're still asthmatic. We've done methacholine challenges before and after aspirin challenge, unchanged. But what's really important is that they're totally cross-desensitized to anything else that inhibits COX-1. So even at 325 milligrams of aspirin a day, you can take PRN, NSAIDs of any type. Another really important thing is that there's a refractory period that lasts anywhere from 2 to 5 days, in which the person, if they didn't take any aspirin, could still take a full dose aspirin and not have a reaction. And that becomes really important because patients have had a food poisoning or a viral gastroenteritis and just couldn't keep anything down, or they were off on a safari somewhere and they lost their aspirin tablets or whatever. So it's really good to know that within a 2 to 5 day period, they can not take aspirin and then take it again and be okay. As you get further down towards the 5 days, there may be a mild reaction that an inhaler will help. It may not be completely benign, but at 2 or 3 days, it's really completely benign. And again, we now have like one patient who we couldn't desensitize, but it really was more, I think, because the patient didn't want to keep on going. I mean, some patients will have reaction after reaction after reaction, but if you persist and they're willing to persist, you can really desensitize anybody. So if somebody has not had aspirin for 2 or 3 days, we just have them take the aspirin at home, take 2 aspirin, call me in the morning kind of thing. If it's 3 to 5 days, we will have them restart the aspirin at home still, but they sort of do their own little aspirin challenge. But if they're more than 5 days, then we want them to come back to the clinic and be re-challenged. But we know what dose it took to provoke them the last time, so we start right with that. We don't go all the way back to do a whole new challenge. Again, really important to remember that if the goal of somebody is not to treat their ERD, but just to take aspirin for cardiovascular disease prophylaxis, 81 milligrams a day will do that, and you'll be able to take 81 milligrams a day forever. And that becomes then a very quick, rapid aspirin challenge. But they can't take any other NSAID, which is what a lot of them would like to do in addition to the cardiovascular disease prophylaxis. So we usually bump people up to 325, even if they don't need treatment for ERD. Because at that dose, they can take whatever dose of NSAID they want. But we still find that 650 BID is the dose that controls the majority, the 51% majority of patients with ERD. There's a little bit less than 50% in our practice that can get down to 325 BID and do just as well. But in our data is about 50-50. So we always start everybody out at 650 BID because we figure if they're in that part of the group, why not give them the benefit of it? We can always taper down rather than starting at 325 and find in a couple of months they're not doing well and have to bump the dose up. I grant you that there are papers published. I didn't put the data in here because it would make the talk even longer, but there are papers that are published that suggest that doses as little as 100 milligrams a day, certainly 325 a day, work. And I think they work, but it's a question of how well they work. So I know that statistically it's not the right thing to do, and it is a bit of apples and oranges, but I played with our statistics and our p-values versus their statistics and their p-values. And say, for example, sense of smell. So on a scale of 0, no sense of smell, 4 being perfect sense of smell, AERD patients are at 0 to 1. So post-challenge, desensitization, and treatment with 650 BID, they're at 3 or 4 out of 4, where the other studies are at 2 or 3 out of 4, when you get 100 milligrams or 325 milligrams a day. So yes, it works, but it doesn't quite work as well. And when you go down all of the data, repeat sinus surgeries, repeat polypectomies, bursts of steroids, all that data, you can get statistically significant data with lower doses. But the clinical significance is with these doses. So we still treat with these doses. What do you do if the challenge is negative? Because the holy grail is to have a negative aspirin challenge, and we're reasonably close with nasal ketorolac and all the pretreatment that we do. So it's either because the patient just doesn't have AERD, but what if they really were silently desensitized? So what we know from the data, and what you know if you treat enough of these patients, is that they require bursoprednisone or polypectomies usually every quarter. So if somebody can go 3 or 4 months on that dose of aspirin and maintain their sense of smell, you don't see any polyps in their nose, that person is responding to aspirin, and they must be an AERD patient, even though they had a quote-unquote silent desensitization. If their polyps are back after 2, 3, 4 months, then they're not. Either they didn't have AERD or they're not a responder. So either way, they're then off of aspirin. Because you certainly don't want to give somebody 650 of aspirin for the rest of the day wondering if it worked. So again, we usually look for a clinical reassessment at about 3 months. How likely is it when you're taking a patient's history that they're going to really have AERD? So the data is that if you just look at a group of patients that have the phenotype, chronic rhinosinusitis, nasal polyps, and asthma, it's about 40% of that group. But if you bump it up to just having had one adverse reaction to aspirin or an NSAID, then the likelihood of getting a positive challenge is now up to 80%. So it's that good a history. But if they've had 2 reactions to NSAIDs, it goes up to almost 90%. And if that reaction culminated in a hospitalization for asthma, it's virtually 100%. So you can kind of gauge what the likelihood is of somebody having ERD even by history. And that may help you figuring out who you can challenge. Now, where do you do the challenge? Well, we've been promulgating for years it can be done in the office. But for a while, the practice parameters were saying, well, what if the patient had a really severe field historical reaction? I wouldn't want to do that patient in the office. But there's actually no correlation whatsoever between the severity of the historical reaction and the severity of the challenge reaction. And we published that in 2007, and it really confounded people, but it made perfect sense to us, because number one, we do a graded challenge. We don't just give somebody 650 of aspirin. Number two, we have them under perfect asthma control. A very common aspirin scenario is somebody's having, say, premenstrual asthma, somebody's having URI-associated asthma, and they take an NSAID for the fever, the pain, whatever, so they already have unstable asthma, then they take full-dose NSAID, and they have a big reaction. That doesn't happen when you do a challenge. We have good asthma control. Also, we pre-treat. There are patients who may have had chronic sinusitis, never even had asthma, and their first asthma attack is the first time they take an aspirin or an NSAID. They don't even have a rescue inhaler. They don't even have a diagnosis of asthma. They can have a big-time field reaction, but they can have the most mild reaction when you do it in the clinic. So there's just, again, no correlation between the severity of their historical reaction and the challenge reaction, so everybody can be challenged and successfully desensitized in the office. And then, as I'm sure you know, anybody with AERD will react to any of the COX-1 inhibitors. You don't need any prior exposure. It could be with their very, very first dose of an NSAID, and it could be somebody who's been taking NSAID monthly or regularly, and they just happen to get a reaction. And obviously, avoiding COX-1 inhibitors don't really help them. The one remaining highly selective COX-2 inhibitor, celecoxib, can be taken with impunity in anybody with AERD, even if they're not desensitized. And if patients don't want to get Celebrex, can't take COX-1 inhibitors, plain acetaminophen is always tolerated up to 650 milligrams, but about 25% of AERD patients will get a much milder reaction than they get to aspirin with the extra strength acetaminophen 1,000 milligrams dose.
Why is that?
It's a very, very, very weak COX-1 inhibitor, so if you get the dose jacked up to 1,000 milligrams, then again, a quarter of patients have a mild reaction because they're just that exquisitely sensitive to inhibiting COX-1. But the dietary, I don't think it's in the slide actually. Yeah, but dietary salicylates have no COX-1 inhibitor activity whatsoever, so they are absolutely fine. And the drug salicylates, choline, disalicylate, trisalicylate, they are even weaker COX-1 inhibitors than acetaminophen. So you'd have to take astounding doses of those, but usual prescription doses don't have any problem with that either. But the problem is that because they don't inhibit COX-1, they're not anti-inflammatory, so they really don't offer anything any better than the acetaminophen does. So really, you're better off using celecoxib if you're going to use anything in somebody who's not desensitized. So this is a 2008 paper, and we were at 1,400 desensitizations. So they're really, we only had to use epinephrine a couple of times for people that had systemic histamine release. So it is a cost-effective and we think safe thing to do. The biggest problem with it is that about a quarter of patients have to stop aspirin within the first year because they get GI upset. It's this very weird let's call it my stomach hurts. It's not acidic, it's not heartburn, it's just my stomach hurts. So when you get this in the patients, you can always try decreasing the dose. If they're on 650 BID, you can always try 325 BID. Usually have them hold the dose for a couple of days and then restart it at a lower dose. You can try using enteric-coated aspirin. The absorption of that is a little bit more erratic than the regular oral tablet, so you may not be getting quite the same dose. So I think everybody should be on 650 BID of the enteric-coated stuff, but you can try that. When that doesn't work, you can go to an H2 receptor antagonist. That works some of the time. You can bump it up to a PPI. Sometimes that works. We've only had a couple of misoprostol failures. Because we think aspirin knocks out prostaglandins, and PGE2 is a prostaglandin that they have very little of to begin with, and it's the stomach cytoprotective prostaglandin from acid. So when you knock that out, you can expect to get kind of an aspirin, which is acetylsalicylic acid-induced gastritis. So if you replace it with misoprostol, that usually winds up working. Not an easy drug to take because it itself causes a lot of GI upset. So what I use is it comes as like 100 microgram, 200 microgram doses. I usually just use the lower dose just with the aspirin tablet, so it's like 100 micrograms BID, and that patients seem to tolerate quite well. And again, that almost always works. This I think you just get from the handout, but it is really important, and I think something that people don't always think about, and you have to really think about it, is the second one from the bottom. You have to get rid of the nasal polyps to start. So aspirin, for whatever reason, doesn't make polyps disappear. It prevents them from regrowing. So whether you want to do a medical polypectomy with a couple of weeks of prednisone or a surgical polypectomy, you want to do that a few weeks before the procedure for two reasons. If you do it too long before, the polyps can come back. These are the most aggressive polyp formers there are. And if you do it too quickly and they get a big nasal reaction and they just had surgery, you may get to be a little bloody, a little bit of a mess. So 2 weeks is usually a perfectly reasonable time. Out to 4 weeks is usually pretty reasonable. But during that period of time, you want to do a surgical polypectomy or just have one, a burst of prednisone right up to the point of the challenge. We'll go over the different challenge procedures because we started out with the oral aspirin challenge. This was the gold standard for many, many years. Actually went up to 650 on day 2, but we're no longer doing that. I really recommend anybody do that because you have the most likelihood of getting a reaction. In Europe, they have something that they can use either diagnostically or for a challenge, but we don't have it, so there's no point in talking about that. But we developed sort of an analog of that rather than having an aspirin analog, a ketorolac, an NSAID analog. So there actually are reports of eye drops with ketorolac in it triggering asthma. Obviously, it must have been an ERD patient, but you can use it as a challenge if you put it in somebody's nose. Again, not going to bore you with the details here because it's in the handout, but if you're not doing it and you want to do it that way, this is how you can prepare the ketorolac. You just need to get an empty spray bottle, and they're getting a little bit harder and harder to get because we don't get a lot of samples anymore. You can actually buy them online, just empty bottles. We have some nice glass ones, actually. But anyway, the instructions will be in the handout, and this is really the nasal ketorolac challenge. But basically, you can see that the nasal part's over pretty early in the morning. So by mid-morning, they're already getting aspirin. So it's only taking like a day and a half. We're working on trying to get it down to a day, because I think that if we, instead of giving 60 and 60 in mid-morning, we just went ahead and gave 120 or 150, then you could, if the patient doesn't react, and it's all based on not reacting to anything of significance, you could really get in the 325 dose late in the day. So we could conceivably get it down to a one-day challenge. Again, somebody who doesn't have much of a reaction, if you have a full-fledged asthmatic reaction, you have to go treat that, wait for the patient to recover. That's going to spill over into the second day. But for the majority of the reactions, when they're quite mild, we may be able to get it over in a day. But we're looking at our data in the 60 and 60 and trying to figure out how many patients reacted to which of those 60 milligram doses and how severe it was. And if it's looking reasonably good, we may push to a 120 or 150 milligram mid-morning dose. So we have a lot of data, again, I'm not going to bore you with that, that shows that doing it with the intranasal ketorolac first and then moving to oral aspirin challenge is not only faster, but it's also safer. There are far fewer laryngospasm reactions, far fewer GI reactions, far fewer extrapulmonary reactions, but also less drop in FEV1 overall. So again, we heartily recommend that you go over to nasal ketorolac. So David Kahn published an article last year about this hourly aspirin desensitization protocol. So one huge caveat is that he didn't do this on every single AERD patient. He did it on patients who said, my reaction occurred within an hour. Because our data is actually that it's about 100 minutes on average before we see a reaction to an oral aspirin challenge. So that's obviously way over an hour. So we don't think that a lot of patients actually have reacted within an hour, so I don't know how many patients this is going to be useful for, but also how reliable is it if this reaction was a year ago, 5 years ago, 25 years ago, that it happened within an hour? I don't know how the patient could really know. So that's already a problem to start out with. And because if their reaction is going to take longer than an hour, then we've loaded them up with a lot of aspirin, and if they're going to be reacting to a dose that they got an hour or two before that, then they're going to have probably a much more severe reaction because we've got a lot more aspirin on board. But, and if you can't see this, again, you can just look in the handout, but if you actually compare side by side the SW, that's the Southwestern Texas, the Kahn protocol, with our ketorolac protocol, and you can forget about the 3-day oral aspirin challenge, they had more bronchospasm. They had 75% of the patients got asthma with their challenge. Only 32% of ours got asthma with the intranasal ketorolac. So the ketorolac was still safer. And then if you look down at the bottom, they were able to desensitize 29% in one day. We had 0% in one day because it's just not a one-day challenge. But they sort of only had 29% they could get out in a day. Overall, it took their patients 1.6 days and took our patients 1.9 days. So it's really only a 0.3 day difference. And again, they were looking at the probably mildest patients who said they had a reaction within an hour. We were taking all comers. So I don't really know exactly what it offers. So we published an editorial on that study, and we're saying again, according to our data, only 42% of patients who have nasal polyps. Also included in his group were people that just had rhinosinusitis, had the AERD phenotype, who had no aspirin history at all. Right? You would think like that may be a group you could do more quickly. But again, and by saying that his study was safe, we find only 42% of patients even react to aspirin who have that phenotype. So if you take out those patients from 42% of those patients from his group, the data sort of falls apart. Again, our average reaction time was 102 minutes, which is way beyond the 60 minutes that he's giving the doses. They had more bronchospasm, and again, only about 30% completed in a day. So it is kind of convenient, but I'm not sure that that's what you should be doing. Okay. Oops. So I think I'm going to finish up on what to do with the patient who comes in or the patient you get a call from the cath lab, a patient who has quote-unquote aspirin allergy, they're either having an acute coronary event or they're ready to get a stent or something like that. What's really important to understand is there is not a single case report that convincingly shows anaphylaxis to aspirin. This was really shocking to my group, and I posited the fact that I think we don't have to worry about somebody, even if their medical record says, even if the patient describes anaphylaxis to aspirin, that they did. Because you can get anaphylaxis from a single NSAID, right? That exists. And how many times do people not even know what they got? But if aspirin caused anaphylaxis, we would be seeing that all day long in our practices. Because if aspirin is going to cause anaphylaxis, it's because it's a salicylate, right? It's acetyl salicylate. So it would have to be the salicylate moiety that was causing the anaphylaxis. Because dietary salicylates are ubiquitous, we would have to either all be desensitized to it, tolerant to it, because we're eating it all the time, or we would see patients day and night who had anaphylaxis after they eat because they're always eating salicylate. So just based on that concept, I said that I don't think aspirin allergy, true IgG-mediated allergy, can exist, and therefore anaphylaxis can't exist. I got tremendous pushback from the group. We did an exhaustive search of the literature. The best we can come up with were 2 patients that had a positive skin test of this lysyl aspirin, but who knows what to make of that. They didn't have anaphylaxis. And we went through all the old articles about anaphylaxis to aspirin and NSAIDs that were reported out of ERs, and there was not a single case that was convincingly anaphylaxis from aspirin. So with that, we got pretty bold with our protocols. So there are a number of protocols in the literature. Again, I'm not going to bore you with those details. They all show very successful rates of desensitization, but that's because, ready for this, we found out that 50% of patients who have aspirin allergy on their chart had GI upset. This is the Scripps database. So if you start out with 50% of people that had GI upset, anything you do to quote-unquote desensitize them is going to look really successful. So here's what we do. In a non-AERD patient, who again is having an acute coronary event, getting a stent or whatever, we don't pre-treat them. We just go right ahead and give them half of a baby aspirin. 90 minutes later, another half of a baby aspirin. Done. 90+% of the time, nothing happens. You're done. Now, if the patient wants to go up to 325, and a lot of them do, we do that later as an outpatient. We're not going to sit there in the middle of an acute coronary event or a stent and take time away to bump them up to 325, because everybody's happy when the cardiologists say we're happy when they're on the 81. So that becomes just an outpatient thing. We do the same dosing for AERD patients. The only thing is that we'll pre-treat them. So we'll give them a dose of LABA. If we know if it's an elective stenting procedure, we'll go do the same pre-treatment that we do for regular AERD patient. But if not, we just give them a dose of montelukast, we give them a dose of a bronchodilator, go 40.5, 90 minutes later, 40.5. Because when we looked at our data over the years when we did the oral aspirin challenges, the average provoking dose was right at about 45 milligrams. If you remember, we used to do a 30 milligram dose and then a 60 milligram dose. And a lot of patients reacted to the 60 milligram dose, pretty mild reactions with the 60 milligram dose. So we knew the 40.5 milligrams was going to be something that patients would probably tolerate reasonably well, and they do. So it's really pretty easy peasy, if you will, and something that shouldn't be frightening or shouldn't take horrible times out of your day, because it's to get people to 81 milligrams, whether they have AERD or not, is pretty simple. And then we do have a protocol to increase to 325 just by going from the 80 that they're on, so basically 1.5 tablets, and then 2.5 tablets, and then they're there. And it takes, again, about another half a day to get through that. But that we do totally as an outpatient. So that, and we're going to ask questions. So this is where I live the other half of the time. I'm not in Mexico, so it's not half bad. Yeah.
So you do mention on your slides the use of the leukotriene inhibitors. How do you feel that's essential for some of these patients, or can you?
So in the coronary setting, if it's really acute, you're not going to be able to give it. I mean, you can give it, but it has an onset of action of about an hour. So we really try to hold off the challenge for an hour, hoping that at least at that point it's sitting on some receptors in their respiratory tract. Because you're not looking, what's nice is you're not looking to get a plasma level, because there's nothing about having a plasma anti-leukotriene level that's important. You want it sitting on the receptors of all their respiratory tract. So we hope that that's going to happen in an hour. At least that's what we try to buy an hour. When we do it in the clinic and we have time, we'll give it often for a week. But that's more just because we do it, right? So, but we give it because in our studies, a single dose, not a single dose, I think we did 3 days, but dosing with montelukast prevented most of the asthmatic reactions, like 90% of the asthmatic reactions, and you would sure like to do that in somebody that has an acute coronary situation. So we usually try to buy that hour and get the leukotriene modifier in.
So you use it in most all of the patients there?
The ARD patients, not again somebody who just says,
Right.
when I was 12, I got a rash from aspirin.
Okay.
Do you think that in your run-of-the-mill triad asthma that leukotriene antagonists are of that much value?
As treatment for ERD, no.
Yeah.
I mean, there are a few patients who seem to do brilliantly and their polyps stay under control, but it's a really, really distinct minority. Again, the data suggests that it's statistically significant over placebo, but it's not terribly clinically significant.
And with mepolizumab treatment, is a possibility here with the eosinophils seem to be driving the inflammatory response? And
Yeah, so sort of two camps. There's no data, but two camps. So because I was at the last Western meeting last January, so Larry Borish was there, and he thinks it's going to be a cure for that disorder. But I don't know that it is, because there are a lot of different ways through leukotriene pathways that you can get to eosinophils that having anti-IL-5 may not manage, as I'm sure you know. And these people have ramped up everything in their 5-lipoxygenase pathways, so they may be able to get to eosinophils by different pathways. He thinks it'll do it because he really thinks that IL-4 is involved in this group. They do have upregulated IL-4, that maybe they do really need IL-5 to do it. I don't know. I still think overall, though, that dupilumab, the IL-4R receptor blocker, is going to be better than even mepolizumab. And that's actually, that was just published. It was very effective for nasal polyps. So they're actually going for an indication for nasal polyps for that drug. So that's one I think may work even better than mepolizumab. But when you look at the cost effectiveness, it's cheaper than some aspirin. And then they can take other NSAIDs and do all these other things.
Is Celebrex the only safe drug that we have?
So it's the only one that we have because the FDA got rid of all the other ones. So it's the only highly selective COX-2 inhibitor that there is. And you may have heard over the weekend that it was sort of blessed as not being any worse than the Proxen or ibuprofen for a coronary artery disease. Not that it was good or safe, but it wasn't any worse than any of the other non-specific COX-1 inhibitors.
Yeah, they didn't have a placebo group in that study. It would have been interesting if they did.
Yeah.
Because then maybe they would have shown there was no increase.
Yeah. I mean, there's no doubt that if somebody's going to be on because you know the story about why only aspirin works. Because why don't we treat these people with naproxen or ibuprofen or something else like that? And the reason is that they are just competitive inhibitors of COX-1, so they're kind of falling on and falling off the enzyme. There's no ongoing effect. So if you have platelets and you're trying to paralyze them and they're going in and out of the COX-1 effect, it's not that effective. So aspirin is unique. It doesn't look anything like any other COX-1 inhibitor. It doesn't work like any other COX-1 inhibitors, which physiochemically try to block this COX-1 enzyme. It is, and the reason why other salicylates don't work is aspirin is acetyl salicylate. It literally acetylates the COX-1 enzyme and destroys it. So what's unique about platelets versus any other cell in the body is that they don't have a nucleus. So they can't make another COX-1 enzyme to do anything for coagulation. So once a platelet is seen aspirin, it's done. You have to get new platelets. So it takes very little aspirin and that's why 81 milligrams works so nicely. But we use it here because, again, it's destroying the COX-1 enzyme, and we need that to be that inhibited, if you will, to work on these patients, not the COX-1 inhibitors. So getting back to the COX-2 inhibitor, that's not going to have any effect on COX-1 at all. But if somebody's taking it every day, so they're on Celebrex consistently, it's a molecule which can semi-obstruct the COX-1. It's still a highly selective COX-1 inhibitor, COX-2 inhibitor, but it's not complete. So the worry is that you may be getting some effect in that COX-1, that preventing the effect of COX-1 that would actually lead to not to more heart disease, but would be, you wouldn't have any protection from heart disease even if you were taking aspirin. So I don't know that, because the Vioxx studies that the FDA really slammed, I mean, they looked pretty bad. The Celebrex studies were not quite bad. Again, they're not saying that it's good. They're just saying that it's no worse than the other ones, which isn't necessarily that good.
Any more thoughts on why these patients are so sensitive to alcohol?
Yeah, I know, but it's exquisite. I mean, it's a good historical thing if you're trying to figure out who's an ARD patient and who's not, especially if somebody hasn't taken aspirin or NSAID because they had polyps and somebody told them not to. And just ask them if they drink alcohol at all. And if they say absolutely not, that really puts them up there pretty high. They're exquisitely sensitive, even to sips of alcohol, and get complete nasal congestion. Maybe even a little bit, they feel a little bit wheezy too. I don't know why, because it's not a COX-1 inhibitor. I assumed it was the fact that they're already pretty swollen and alcohol is a vasodilator, but they describe them just like a sip or two and happening very quickly. I don't know why. But also another historical thing is the spearmint. All the mints, these people will not use mint toothpaste. Most of them are on just plain baking soda toothpaste. There's something about the minty taste that also seems to give them pretty immediate nasal congestion.
Can you take a look at the screen there in case we have people listening to extend the meeting?
Sure. Sure.
You click on yes.
Oh. I can't see my screen. I'll say I lose it in the white. So I don't know where yes. Let me see if I can do that.
I think it's on this. It's not you.
I don't think it's on the computer.
It's not.